But to get a much more detailed view on this, we've got 3 excellent case studies, and I think we'll go straight on to case study number 7, which is Muriel Raymond, who's from Oxford in the UK, who's going to talk about chimps of salmonella. Do you want this or just?
Good morning, everyone. Wow, that's very loud. My name's Marielle. I'm a GP from the UK, and I work in Oxford with the Oxford Vaccine Group on human challenge studies with typhoid. So I count myself the luckiest person here because 9 days ago I wasn't going to be here, and my colleague Malik had a job interview. So he asked me last Monday, he said, would you like to go to Bangkok? And I said, yes, please. So unexpected gifts are the best. So it's been interesting, just the chats I've been having yesterday about the work that I'm doing. It's been a sort of a varied response. So my plea today is just keep an open mind about human infection models. I had one Nigerian colleague say, oh, I'll never get past ethics. So, and then in the Pechakucha session yesterday, I think the Nigerian, sorry, not Nigeria, what was it, Egypt presentation, there was a kind of a canvassing of opinion, you know, is it reasonable to allow an individual to take a risk for the greater good of society? And the blanket answer was no, so that's kind of relevant. But the Myanmar session, they were saying, well, barriers to change are familiarity. So, you know, this is something that I am very familiar with, so I'd just like to give you a bit of an introduction. So, this is Malik's presentation. He's been a little bit generous on the details, so I'm going to have to kind of skip through some slides, but I'll talk you through them. So, what we're talking about today, we're going to do a brief history of infection challenge models in America and in the UK. And then the ethical issues I'm going to divide broadly into participant safety, benefit, thinking about the community safety and benefit, and then talk a little bit about engagement with local stakeholders and the importance of that. So, you know, what is the context? In moderate to severe diarrhea in the under 5s, the 4 most common pathogens are listed there. We only have a vaccine against one of them, that's rotavirus. Furthermore, we know that vaccines against enteric diseases work less well in contexts where the burden of disease is higher. So we know that for rotavirus, for example. I'm not going to talk you through the whole of this graph, but basically that shows that if you have a higher under 5 mortality, you have a decreased vaccine efficacy. Looking at the cholera vaccine, so this was a trial done in 50 healthy US volunteers voluntarily infected with cholera. That's an interesting one. And they showed that this vaccine actually was effective at protecting people. And on the basis of this vaccine, actually, the FDA approved this vaccine for cholera in 2016. However, that did not translate into the field. This is data from Indonesia, and it didn't show any protection. So, challenges for translating information from high income to low middle income. You know, the vaccine that we've shown to be effective elsewhere, is it going to be effective in a different setting? can we translate, or can we extrapolate from different age groups that we're testing vaccines in? Do we have enough information about safety? Are we going to get the vaccine dose right in a different population? And then there's other more subtle things about herd immunity, thinking about how effective the vaccine is going to be. Just to explain why we need a human infection model for Salmonella particularly, Salmonella, there's about 20 million cases documented worldwide or estimated, and about 200,000 deaths. With rising antimicrobial resistance, the WHO has named this as a priority pathogen, and Bill and Melinda Gates have got on that bandwagon and decided that it's a very important disease to be fighting, so they're giving us a lot of money, which is great. At the moment, we don't have good diagnostic tools. We don't know what antibody level correlates with protection, so we're kind of guessing on that. And it's also a human-restricted pathogen, so we don't have a good animal model, which is why we need to involve human volunteers. So just to give you the history of this infection model, the first challenge studies were done in Maryland in the US between 1952 and 1976. And basically during these studies, they worked out how much of the bug you have to drink to get sick. And they described participants who drank the bacteria and didn't get sick but had the bacteria in their blood. Then they looked at mucosal changes in the gut, looked at different treatments, and also trying to establish the effect of different strains, looking at different vaccines, so whole cell killed vaccines, and interestingly looked at the live attenuated oral vaccine TY21A, which we use for travellers today still. Basically I think that fell out of favour because it was deemed a bit unsavoury. And then my understanding is that with improvement in regulatory procedures, accountability, and with the help of our friend Bill Gates, we've had a bit of a resurgence in re-establishing this model. So what have we done in Oxford? Over 400 volunteers have been challenged to date. So this has been going on since about 2010. And we've established a human challenge model in Salmonella typhi and also paratyphi. So paratyphi is sort of the cousin of typhi. It's emerging as a major threat as well, and there's no current vaccine against it, so it's a bit of a priority. So since 2010, there have been about 6 challenge studies to establish the dose of bacteria that is required to reliably establish infection in volunteers to get an attack rate of about 65%. A couple of the trials have been looking at vaccines as well, and a novel oral vaccine was trialled, which is called M01ZH09. Actually, that showed that there was no benefit over the control vaccine, which wasn't a typhoid vaccine. So yeah, that didn't show any benefit. And there's also been a recent trial looking at the conjugate, an intramuscular conjugate vaccine against the traditional polysaccharide vaccine. So if you guys have had a typhoid jab into the arm, that was the polysaccharide vaccine. Okay. Talked about paratyphi already, and yeah, we're looking at a lot of sort of targets for diagnosis, looking at the host response. And what's been quite interesting is because the studies have been running for 7 years, we get participants who come back. So this is like an encouraging thing for the ethics committees. They actually come back for more. We give them typhoid again. And that's very interesting for us to look at, what happens in reinfection, which I suppose is a model of what might happen in a low and middle income setting as well. We've also looked at, more recently, at a strain of typhoid that is toxin negative, just to see what the pathogenesis of that is. So what do? We take a lot of volunteers, we get them to drink a solution that contains a set amount of typhoid bacteria, Salmonella typhi or Salmonella paratyphi. We get them back at 12 hours and do blood tests, and then we get them back every day for the next 14 days to do daily blood tests, daily blood culture, daily safety bloods, and to be reviewed by the study team. So they have observations taken, and we see how they're doing symptomatically. So I said beforehand we have an attack rate of about 65%. So the diagnostic criteria is either having a fever of above 38 degrees for a 12-hour period, so persistent fever, or growing Salmonella typhi or paratyphi from the blood culture. So in that event, you start antibiotics at that point in time and receive a 14-day course of antibiotics. And in the event that you are not diagnosed, at the end of the 14-day period after challenge, you receive 2 weeks of antibiotics. So everybody is treated with antibiotics, and we know that the strain that we use is sensitive to antibiotics. This is just a slide presenting the data from comparing the polysaccharide vaccine, that's the one that you normally get as a travel vaccine, with the conjugate vaccine. So this was a study done comparing those with a control arm, which was a meningitis vaccine. So you can see here, the y-axis is the amount of people who are getting typhoid, up to 100%. And then on the x-axis is time in days. So as you can see, the red line, that's a control vaccine, that's a meningitis vaccine. You can see that a larger proportion of those people are getting diagnosed with typhoid fever. This was just for Salmonella typhi, sorry, just to point that out. And then the blue and the purple lines are the conjugate and the polysaccharide vaccine. And as you can see, there's not much of a difference between the two. Now, this is a really nice demonstration of non-inferiority of the conjugate vaccine. This is relevant because we can't give the polysaccharide vaccine to children under 2. And a big part of the burden of typhoid morbidity and mortality is in the under 2s. It was shown that the vaccine efficacy for this was about 55%. If you use the field definition for typhoid fever, so you get rid of the asymptomatic blood culture positive individuals, the efficacy of that increases to about 87%. So on the back of this, about 20,000 children in Nepal are about to be vaccinated with the conjugate vaccine. So this is having sort of major changes, sort of inspiring further research. Okay, so I think Nick talked about this a little bit earlier, but why would we try and translate this into a low or middle income setting? And so yeah, it's the same stuff really. It's just immune priming, different microbiome, different genetics, and the fact that, as I said beforehand, we know that it doesn't necessarily translate from a challenge setting in a high-income country to the field. And this is already happening. There are enteric pathogen human infection models happening. These are 2 papers from Thailand. One is for cholera and one is for Shigella. They're both from 2012, I believe. Okay, so this does raise eyebrows when you tell people that you give people typhoid for a living. So I'm just going to kind of go through the safety elements and the possible benefits for participants. This is the first chunk, okay. So yeah, basically we have a very good safety profile, and safety really is the primary concern of the study. Benefits to the participants are admittedly limited. So they get a vaccine if they're in a vaccine study. They get a health screening, which they do appreciate, and sort of that you get quite a detailed physical exam, history, ECG, etc. Admittedly, that can cause a few problems as well when you find incidental results that you're not sure what to do and you push it back to their GP. But the participants still seem to appreciate the fact that they've had a health check. In terms of thinking about the risks associated with getting typhoid, we do emphasize to participants that this is a potentially fatal disease, and that's why we're so interested in developing a good vaccine. So if typhoid is left untreated for a period of weeks, there's a risk of intestinal perforation and death. So we do tell participants that. So obviously, in the field, that's where they're not monitored, and that's where infections can be left undetected. So we actually have a very good idea of what participants can expect from symptoms from typhoid. It's like a flu-like illness, so we explain that to them, the sort of duration of illness that they can expect. And actually, it's very predictable, and I think, in terms of risk, this is a lot more explicable and predictable than taking part in something like a phase 1 study where you're actually not really sure what side effects you might be expecting. I'm just going to skip these, I don't have time. So, thinking about informed consent, this is really carefully done, actually, and so we do telephone screening just to kind of introduce people to the idea of the study, to make sure that they're eligible, answer any questions they might have. We then send them a really detailed study information booklet, which goes through all the steps of the study. When they come in for their screening, they have that full medical screening. We do a kind of psychological questionnaire. We check with their GP that they think that they're fit to enroll. And we also give them a quiz to kind of check their understanding as well. Expectation of risk is really important at this stage. It's quite interesting. Some participants just think that they just won't get sick. And generally that's the sort of young male participants who do actually tend to suffer from worse symptoms than the females, interestingly. But yeah, I tend to say, listen, you've got a third chance of not getting sick, but better to assume that you're going to get sick, and you'll just be pleased if you don't. Okay, so thinking a bit more about safety. So they come every day for the 14 days. We do have access to a 24-hour emergency contact, so they give us a name of a person who's signed to say that they're happy for us to ring them in the event that we can't contact the participant if we're concerned about their safety. They also know that we can do a home visit if we can't get through to that contact, and they're aware that we actually can call the police if somebody goes completely AWOL. We do have access to inpatient facilities in the event that someone was actually really unwell. I mean, we've actually only had one hospital admission out of the 420 cases, and that was short-lived. And there is ITU backup if required. We keep an eye on our participants by getting them to do an e-diary, which is really helpful. So they list their symptoms from 0 to 4, which is severe symptoms, and they also record their temperature twice a day. So that's quite a useful way of us keeping an eye on whether someone's getting unwell or not. And in turn, they have 24-hour access to the study team. A doctor is always carrying the on-call mobile for advice or, Okay, so just thinking about translating that to a low or middle income setting, this would be more challenging because less healthcare infrastructure, more stress on staff, and one might think, well, if you don't have enough staff to look after your existing patients, why are you going to make people deliberately sick as well to kind of increase the burden? There's a big laboratory burden. There's a theoretical increased risk of disease severity in primed individuals. And you're more likely to have somebody who's already had some health condition in the past, so you're less likely to have a clean slate, less likely to have access to primary healthcare records, so you might actually not really know that somebody's been unwell in the past, and an increased risk of gallbladder disease, which increases risk of chronic salmonella typhi carriage. So I think this is a really important point, the second one. The safety measures should be at least as stringent as in the UK model, because of these other challenges. Would an outpatient model still be appropriate in this setting? Would you be able to reliably monitor people? Would they reliably come back? Consent is also a big issue. You want to be taking very careful consent, make sure that it's appropriately worded. And our volunteers are reimbursed for the time that they miss off work and for the inconvenience of blood tests, travel, etc. It would be important that reimbursement was proportionate to the country, the host country. Otherwise, you're thinking about incentivizing people. Okay, so we talked about participant safety benefit. Now we're just thinking about community safety and benefit. So the big thing here is the risk of transmission. Salmonella typhi and paratyphi is transmitted feco-orally. So if you give people, put it in one end, it's going to come out the other end. So what we do is actually, our participants have got access to flush toilets, but we still go through very stringent hygiene measures, how to hand wash, wiping down toilet handles. We tell people not to prepare food after they've drunk the typhoid bacteria. And then we also give written information to the household contacts, informing them that somebody in their household is about to have Salmonella typhi, and offering them a screening opportunity if they want to have their stool checked for Salmonella. We then establish clearance from the bacteria by taking 3 clearance stool samples at least a week after antibiotic therapy has completed. So what does the public think about this? This is public engagement. This is just a newspaper article. On the left, you can see something about the Queen visiting somewhere. And on the right, it talks about what we're doing in the Oxford Vaccine Group. So one might argue that is slightly small print and might be missed, but it's important to go through procedure. Okay, so yeah, let's think about that in a low and middle income setting. That is going to be amplified. You've got poor sanitation. How do we achieve community consent in this setting? Much more difficult than just thinking about a sort of confined household. Thinking about sort of community benefit, I mean, it's possible that actually these sorts of studies would improve laboratory services, like improve healthcare services, if there was investment into those areas. Okay, I'm sure that I'm running over time, so I'm sorry. So briefly thinking about sort of the engagement with the local stakeholders. So this is really critical for actually getting people on board if it's something that low and middle income countries are thinking about doing. So as you can imagine, there is a whole host of regulatory and ethical framework approvals. So we liaise quite closely with Public Health England, and we tell them about all of the cases that we're challenging, when they're diagnosed, when they're treated, when the stool samples are cleared. Interestingly, with the Medicines Healthcare Product Regulatory Agency, that's the MHRA, the challenge agent is not listed as an investigational medicinal product, unlike in the US. So we don't actually require their approval for that specifically, but that would change on a country-to-country basis. We also liaise with the Department for Environment, Food and Rural Affairs, that's DEFRA, and they've done some very interesting studies for us. We did a genetically modified strain of typhoid without the typhoid toxin, and they put it into soil. They saw how long it would persist in the environment. Quite interesting work. Okay, I mean, thinking about the potential risks to this, the principle of first do no harm. There's a potential reputational risk to the institution if there were to be bad outcomes. This would really damage trust between the community and researchers. Thinking about setting up a model somewhere else, quality control is really important, and like harmonization of procedures. Particularly the challenge agent, it would be really important to kind of to harmonize that, and the idea would probably be to freeze pre-prepared challenge agents and actually then share those appropriately. If you're interested, this is a review article about what needs to be in place to consider these things in specifically Malawi. That's a review article by Gordon. So just to summarize, this human infection model has been successfully established in Oxford. Potentially this is a springboard for accelerated vaccine development. Could be cheaper, smaller numbers than if you're doing large observational studies in the field. Could be a game changer. So yeah. I'd like to thank Bill and Melinda Gates for paying my salary, for the Wellcome Trust for funding my attendance here, and the Medical Research Council. And this is Team Typhoid, so you can see there's a lot of people involved, like 11 clinical research fellows, 14 research nurses, not all at the same time, but yeah, there's been a lot of people involved. And I would just a shout out for travel buddies for Saturday, Sunday, Monday. If anybody's interested in doing some traveling, let me know. That's it. Thank you.
Thank you, Mariel. That's fantastic. Great overview. Any points of clarification for Mariel? Or should we call you Typhoid Mariel?
Thanks. Just a small question. You said that you were going to inform police if participants do not attend to the visit. How can you manage that with the voluntariness of participation, and actually any participant can withdraw their participation at any moment, but you request the police to go and get them?
Sure, so this is a safety backup. The reason for that was because the malaria challenge model with the Jenner group, who are our sister group, they had a volunteer who was infected with malaria, and then he went missing for a long period, which caused a significant amount of stress for everyone. And he was eventually located in the Netherlands. So on the back of that, it was thought, okay, well, we really need a backup plan, because it's not for if somebody says, actually, you know what, I want to withdraw from the study, we won't be calling the police and dragging them in. It's a funny thought. But yeah, no, it's basically just for safety.
I'm sorry with my ignorance, perhaps. What is the motivation for people to be involved in this study? I know that for many other trials, people get involved, maybe to get treatment. In this case, they are also getting injected with disease, and I'm just wondering what was the motivation. Is it altruistic, or what was?
So Oxford's an interesting environment. There's a lot of academics. So I'd say a proportion is altruistic. People feel that they're sort of contributing to scientific advancement, and they're on board with the vision, like the overall vision of what we're trying to achieve. Other people, I think, are so there is reimbursement for the inconvenience of the blood test, the travel, and also time off work. Now, if you don't work, then that's sort of, it's not really time off work, so you're actually getting money for time off work when you didn't have a job. So that appeals to students. So we actually get a lot of students who are sort of, who that appeals to them.
Okay, thank you very much, Mariel.